Hello, everyone. Good evening. Very honored that you all took the time and effort to join us tonight with the already third SECEC user combined webinar. We had one on rotator cuff pathology, and we had one on frozen shoulders. And this year we decided it was time to move on to the elbow. I think we have an interesting program with a lot of well-known speakers, and we're going to talk about managing elbow stiffness. So we're going to first listen to the talk from Jagwant Singh, who's coming from London.
Good evening, everyone, and greetings from London. My name is Jagwant Singh, and I'm one of the elbow and shoulder consultants at Greenwich. Many thanks to SECEC EUSSER for giving me this opportunity. My talk is on etiology and pathogenesis of elbow stiffness, and I'll also be discussing post-traumatic stiffness. The elbow is a complex hinge-type synovial joint. It has an important role in mobilization and linking the hand, wrist, and the shoulder. It comprises of three articulations: the ulnohumeral, the radiocapitellar, and the proximal radioulnar articulation. All these are within one synovial articular capsule. Soft tissue boundary of the elbow joint is articular capsule, which is weaker anteriorly and posteriorly, but medially and laterally it has well-defined ligament complexes. Looking at the osteology of the distal humerus, the trochlea and the capitellum are anteverted by 30 to 40 degrees, and there is a 4 to 8 degrees valgus. The anteversion is important as it allows the coronoid clearance. What elbow does is that it positions hand in space, allows forearm to act as a lever in lifting and carrying, and provides precision in both open as well as closed chain kinetic work. Any reduction in the elbow range can significantly reduce the ability of hand to reach its objectives. The elbow controls the radius of the sphere, and that has a big impact on the volume of the sphere. Dr. Morey noted that most activities of daily living would require a minimum of 100 degrees arc of elbow flexion extension and prosupination. However, greater motion may be required for personal hygiene, eating and holding phone to ear, or typing. This diagram illustrates why elbow stiffness is a disabling condition. The blue shows area reached by hand with full range of movement of the shoulder as well as the elbow, whereas the much reduced red area is as a result of 90 degrees flexion contracture of the elbow. What is a stiff elbow? Any loss of extension of more than 30 degrees and flexion less than 120 degrees is a stiff elbow. There are predisposing factors which include complex articular congruity, anterior brachialis muscle, and prolonged immobilization needed when there is an unstable fixation. Multiple etiologies, but overall these are atraumatic and traumatic. Osteoarthritis is a common atraumatic etiology, as is congenital, and multiple hemarthrosis. Elbow surgery is also a controlled trauma and can lead to post-surgical stiffness. Bone and soft tissue is what ultimately provides mechanical block to motion, resulting in stiffness. Intra-articular fractures, osteochondral defects, and osteophytes alter the geometry of the articular surface. Incongruous articular surface hinders elbow motion, as does osteophyte formation, which is a hallmark of osteoarthritis. These osteophytes are formed at the olecranon and coronoid tips and lead to impingement in flexion and extension. Extra-articular elbow stiffness is related to periarticular tissues and is commonly seen after traumatic elbow dislocations or fracture dislocations. Tethers and blocks cause motion deficits. An anterior tether and a posterior block would lead to an extension dysfunction, while as a posterior tether or an anterior block due to any of these reasons would lead to a flexion deficit. Understanding this is important as it gives us an insight into the management of these problems. Incongruity of malunited radial head fracture after trauma, heterotopic ossification, or synostosis leads to rotational stiffness. Multiple classification systems have been used. This one by Case is about the structural involvement. The most widely used classification by Dr. Morey is based on location and etiology, and it comprises of intrinsic or articular problems, which could be intra-articular adhesions, fractures, osteochondral defects, and loss of osteochondral defects and malunions. Extrinsic, on the other hand, involve capsule, ligament contractures, and extra-articular malunion. Most of the post-traumatic stiffness are mixed. Various other classifications have been developed. This all-inclusive pathoanatomical classification includes capsule and neurological conditions as separate entities. This classification from Shanghai is based on functional deficits involving flexion, extension, and rotation. The stiffness types and influencing factors stiff classification takes into account the 5 disorders and 6 influencing factors, including ulnar nerve symptoms. It gives us a decision treatment algorithm and takes into account various factors which dictate decision making and outcome. The pathogenesis of post-traumatic elbow is multifactorial, and the etiology of a clinically stiff elbow is often a result of both intrinsic as well as extrinsic factors. Intrinsic causes range from articular incongruities, from initial trauma to impinging osteophytes, loose bodies, and post-traumatic or post-surgical immobilization leading to intra-articular adhesions. The most common extra or extrinsic causes of stiffness include capsule, ligamentous, heterotopic ossification, extra-articular malunions, and neural adhesions. Intra-articular malunion following a fracture can contribute to stiffness due to alteration in smooth articulation and is likely to obstruct elbow motion and in long term lead to arthrosis. It's important to restore the osseous anatomy to allow for this smooth articulation to function. And when this does not happen, there is cross arthrosis. I would like to thank Professor Van Riet for giving us these cases to discuss. Here, this arthrosis has gone beyond the salvage stage. The intra-articular capitellum malunion, it involves 3D planning and decision making with regards to osteotomy and fixation. All these are challenging cases and require a lot of pre-operative decision making. Loose bodies in the elbow are an indication for arthroscopic management and have good results, as do impingement from osteophytes, and they also have good response to arthroscopic management, as we will be discussing later in our talks. Intra-articular metalwork is a devastating complication. It needs revision surgery. Heterotopic ossification, we will have a next talk by Dr. Sanchez on this. Extra-articular malunion, again, the aim is to restore the osseous geometry, but these are challenging cases and require 3D planning, 3D jigs, and fixation. Ulnar nerve problems involve adhesion and also conditions where they are impaled by K-wires. Coming on to the capsular contraction, it all starts as an inflammatory response and then leads to a fibrotic pathway. The fibroblasts are transformed into myofibroblasts, which have increased activity of smooth muscle actin. All this is under the influence of cytokines TGF-beta. Understanding the mast cell myofibroblast neuropeptide axis of fibrosis is important, as it gives us the understanding of the pathology of post-traumatic capsule contraction. Similar pathologies work in Dupuytren's contracture. It has been seen that chronic contractures beyond 5 months do not have myofibroblasts, and this may have an implication for treatment, since any procedure triggering or upregulating the myofibroblast activity in early phase may aggravate fibrosis and contracture, while as similar measures may be well tolerated later on. Thank you very much. We'll take the questions in the end. Thanks.
Good evening, and thank you for the invitation to participate in this webinar on elbow stiffness. My task tonight is to provide an overview of elbow stiffness after trauma. These are my disclosures, which are not relevant to the content of this presentation. We know that the role of the elbow joint is to facilitate positioning of the hand close and away from our body, and as such, when our patients suffer with elbow stiffness, they struggle with many activities of daily living. Loss of motion secondary to stiffness and HO formation is relatively common after elbow trauma. So tonight, I'd like to provide an overview of the pathology that underlies stiffness after trauma, discuss a few elements of the treatment options, provide new information on the role of CPM, and close out with a few words on prevention. Regarding the pathology of the stiff elbow, of course, capsular fibrosis is central and essentially present in every elbow that becomes stiff after trauma. However, it's important to recognize that there are other structures or elements that may be present and also contribute to stiffness, and as such, they may need to be addressed at the time of surgery, and those include heterotopic bone formation, osteophytes, a very irregular articular surface secondary to cartilage degeneration, abnormal shape of the bone secondary to malunion, non-isometric ligaments, and occasionally nerve injuries or nerve dysfunction that can contribute with an element of neurogenic contracture. We owe to Dr. Bernard Murray the distinction of two major categories of post-traumatic elbow stiffness, intrinsic and extrinsic. And this emphasizes the key question to answer when we manage these patients. Is addressing the joint surface necessary to restore functional elbow motion? Regarding the treatment of the stiff elbow after trauma, it basically falls into four categories. Physical therapy and braces, which may help early on, but I don't think it helps that much in the established contracture. Contracture release with or without HO removal, which can be done open or arthroscopic. Interposition arthroplasty and total elbow arthroplasty. Arthroscopic osteocapsular arthroplasty has emerged as a very successful treatment modality for patients with elbow stiffness overall, and we owe to Dr. Sean O'Driscoll the development of a very methodical way to release the stiff elbow arthroscopically by first establishing a view, then creating a space in which to work, then completing the bony work, and finally the capsulectomy. The key is to think about this operation as a safety-driven procedure to avoid nerve injury, and that is helped tremendously by the use of retractors. When we do an arthroscopic release, it's still important to remember the very crucial role of the ulnar nerve. So in our practice, we release the ulnar nerve in every elbow that is taken to the operating room for contracture surgery, and then we typically continue the surgery arthroscopically. And I know that today other presenters will discuss in detail arthroscopic contracture release of the stiff elbow. However, when thinking about this topic, it's important to understand that primary OA and post-traumatic OA are different entities. I think it's somewhat easy to gain motion and clean the elbow in a patient with primary OA. It's actually much more difficult to do an appropriate arthroscopic release in some cases with post-traumatic OA. And I think that is why in a webinar like tonight, we must discuss the indications of open contracture release, which of course they are all relative. They depend on your skills, but I would argue that most of the elbow surgeons today, if they have to remove large areas of HO, they're going to do that open. Patients with a prior ulnar transposition may require open surgery unless the location of the ulnar nerve is identified preoperatively with ultrasound. There is these very difficult cases that have complete ankylosis, which could be done arthroscopically in the hands of some surgeons, but are very difficult to do, and those, for me, are an indication for open surgery. And of course, if you're going to do a large exposure to remove plates and screws, might as well use the same approach to release the elbow as well. There are four main procedures for open contracture release: the lateral column, the medial column, the outer bridge Kasiewagi, and the anterior approach. My favorite is the lateral column procedure described by Drs. Mansat and Murray in 1998, when one can use intervals anterior and posterior to the origin of the LCL to access the joint and release it without generating instability. In general, when one considers an open contracture release, there are a few points to be taken into consideration. First, the ulnar nerve typically needs to be addressed anyways. So if you do a lateral column procedure, you will likely separate a small exposure to release the ulnar nerve, and through that approach, you can also release the posterior band of the NCL, which will give you more flexion. Second, it's important to create a plane between the muscle and the capsule before the capsule is detached off the bone. Once the capsule is free floating, it's very difficult to remove. So I like to create that plane between muscle and capsule, and then with the capsule still attached from the bone, detach it in the margin and then remove it. And finally, think about removing the hardware last. When we're surgeons and we start to do an exposure and we see plates and screws, our instinct is to ask for the screwdriver and remove the plates and the screws. And as we're working on your elbow range of motion procedure, we will want to gain some motion with manipulation, and then there is the real risk of a fracture through the chair risers that are left behind when the screws are removed. So I like to get all my motion back before I touch any plate and any screw, and once the hardware is out, no manipulation. For patients with intrinsic stiffness, in my practice, interposition arthroplasty has been unsuccessful, so even though the complication rate of total elbow for the post-traumatic elbow is not perfect. I'm hoping that with newer implants that are unlinked and provide lateral column load sharing and better polyethylene, we will be able to offer these patients a solution, which is what I typically offer now to my patients that have a stiffness after elbow trauma in the intrinsic category. What about HO formation? We know that the elbow really likes HO formation, and it happens after trauma. It happens after injuries to the central nervous system, after burns, sometimes after some procedures. And we've done a lot of work in our institution to understand what are the risk factors for HO formation at the elbow, specifically after trauma. We have two studies. In the first one, we look at 134 elbows that all had a proximal fracture of the radius or ulna without or with instability, treated surgically, and we identified all the patterns of injury. We tried to analyze how mature the HO was. We then classified them into what type of motion was lost, flexion, extension, pronation, supination, or both, and how severe, mild, moderate, or severe. And what we found is that in elbows with a fracture of the radius, ulna, or dislocation, 40% of the elbows had some evidence of HO by 3 months. However, only half of these elbows had loss of motion, and about 11% of these elbows were taken back to the operating room for HO removal. And these were the 4 risk factors for HO formation: dislocation, open injury, an injury to the chest in the same trauma, and delay between the elbow injury and surgery. So these are numbers that are easy to remember. 40% of the elbows had HO, half of those, 20%, lost motion, 11% were taken to the operating room for HO removal. We did a similar study in 89 distal humerus fractures that were treated surgically in a 5-year period, and we went through the same methodology and physically found exactly the same numbers. About 40% of the elbows had HO on X-rays. Interestingly, in the distal humerus, motion loss was more common for those elbows that had HO, and again about 10% were taken to the operating room for HO removal. These are the risk factors for the 2 categories. So when you're going to remove HO surgically in the stiff elbow after trauma, it is essential to scrutinize the CT scan, carefully assess the location and condition of the ulnar nerve, and oftentimes I will combine medial and lateral exposures. Selectively, some people consider arthroscopic removal, and again, if there is retained hardware, it does not always have to come back out, and if it does, always in the end. So this is a case of a patient with ankylosis secondary to HO formation. You can see how the patient had flaps for coverage after his index injury. We did a lateral column approach, identified the posterior interosseous nerve, removed the capsule and the HO, and then to get to the back, we carefully raised the previous flap, identified the ulnar nerve, and accessed the posterior aspect of the elbow joint through a separate exposure. And you can see how we were able to obtain adequate intraoperative range of motion, and luckily the HO formation didn't come back. However, studies show that HO can actually come back after removal. And the outcome of this operation is actually difficult to tease out because many of the papers mix a combination of HO after trauma, burns, and an injury to the central nervous system. But in general, if you compile all the papers, the risk of HO coming back again after removal is about 10%. And interestingly, the final outcome is very similar if the patient had ankylosis or partial stiffness. Range of motion is actually better than in the stiff non-HO elbow, and the motion in the end is actually similar for the different diagnoses, although the chance of recurrence is higher with neurologic HO. There is a correlation between preoperatively and final range of motion, and motion seems to be worse if surgery is delayed more than 12 months. What about the role of the CPM? When I trained at Mayo Clinic, we used CPM for every single elbow that went to the OR for stiffness. And we know that this can be cumbersome and difficult to accomplish, especially depending on your support system. We just finished a couple of studies that may provide some insight about when to use CPM. We basically found that if you compare CPM with physical therapy after arthroscopic contracture release, the gain on average is about 10 degrees. However, it is very beneficial in patients with a Riet contracture, and it leads to an earlier recovery and less narcotic use. So for me, the indication is patients that have a high rate contracture that really need to recover fast and then worried about narcotic overuse. And what about prevention? We've done a lot of work in our institution with a Mayo model of knee contracture in the rabbit, where we create a contracture by immobilizing the knee in flexion after a capsular injury for 8 weeks, and then let the animals remobilize. We measure range of motion through their alive period and also after sacrifice, and then we can assess the tissue to understand the molecular biology of stiffness as well. And we have found that there are a number of drugs that are promising, and currently we have positive outcomes with use of celecoxib and ketotifen, and we're interested in another molecule called adiporon. So more to come in this, but I think there will be a role for prevention of stiffness after elbow trauma. Regarding prevention of HO, I think it's very controversial. Radiation and non-steroidal anti-inflammatory drugs, they both interfere with bone healing and potentially soft tissue healing, and radiation can actually lead to non-union osteotomy and maybe increase the risk of infection. So at this point, I myself don't use any strategy to prevent HO formation after acute elbow trauma. So in summary, stiffness will continue to complicate elbow trauma in the future. There are various techniques that we will describe tonight for management, and prevention efforts are key. Thank you very much for listening.
Hi, my name's Val Jones. I'm lead physiotherapist at the Sheffield Shoulder and Elbow Unit, and I'm also national delegate for the UK for EUSSER, as well as being the chair of the Education Committee. And today I'm going to discuss examination of the stiff elbow, but looking at it from a physiotherapy perspective. So, we all know the causes of elbow stiffness, and most of the patients we tend to see with a stiff elbow in the physiotherapy world tend to be post-traumatic, whether it's acute, immediately post-injury, or chronic. But also we see patients who present with degenerative disorders such as osteoarthritis, ulnar nerve injuries, and they can obviously predispose patients to neurogenic mediators of capsular contractures. Systemic diseases such as haemophilia, rheumatoid arthritis, etc. Congenital problems leading to stiffness such as arthrogryposis, radio-ulnar synostosis, burns as well because of the soft tissue contracture, and also patients who present with elbow stiffness following a head injury because of not just because of changes in tone, but obviously head injuries predispose patients to developing heterotopic ossifications, or patients who have other neurological complications such as increased tone after a cerebrovascular accident. So first of all is an assessment. We need to take a thorough history where we look at how pain contributes to the problem. Is it pain limiting range or is it true joint stiffness? What are the systemic contributions to that as well? Do they have other problems such as diabetes, which might contribute to the elbow stiffness as well? What are their functional requirements? I think it's really important to actually assess what the patient needs in terms of range, because you don't need full range to have a fully functioning elbow. And it's also important to remember that in patients who are sporting athletes, often their dominant side, if they're a thrower, often has less range of movement pre-injury compared to the non-dominant side. But it's also really important to find out what the patient's attitudes, expectations, and beliefs are. Expectations are really crucial when looking at a patient with a stiff elbow. If they're expecting to get full range, they may well be disappointed. So it's important to actually discuss with them what their functional range is they need to perform everyday activities. And it's really important to find out about their fear avoidance beliefs as well, which we'll discuss later. So we all know, I think we'll have seen this before, following on from Murray's paper, Sardelli showed that you probably needed a flexion extension arc of about 120 to perform everyday activities, especially in light of smaller cell phones, which necessitated more flexion to bring the phone to your ear. And again, pro and supination. And it's really important, I tell my patients, to be able to flex more than extends, because if you can't flex, you've only got your wrist and hand and neck to try and accommodate those flexion movements, and they often can't compensate. So we tend to work on flexion supination so patients can bring hand to mouth, and then work on extension as a secondary problem. But it's really important, as we said, to find out patients' attitudes and beliefs and fears, because this was a really important paper by Joaquin, written in 2019, that showed regardless of fracture pattern and a distal humeral fracture, regardless of treatment, it was fear avoidance beliefs and self-efficacy beliefs at 2 weeks post-injury that actually predicted outcome at 6 months in terms of functional range of movement and functional abilities. So therefore, sometimes it's not so much about what we do with the patients, it's more about what we say to the patients, how we empower them to actually make them feel confident to mobilize early and in a protected range. So the physical examination, after we've taken that theory is to look at the range of motion, and we'll look at modification procedures that I'll look to see whether we think is something either due to muscle tightness or capsular restriction. What's the end feel like? Is it a hard end feel? Have we got a true block from bone, heterotopic ossification, etc.? Or is it more of a springy end feel where we feel that the joint has some give, some play, and we can move into that? We'll do neurological testing as well, where we look at sort of sensory and motor testing, muscle length, inhibition and strength, the general functional abilities, and also general health. And we'll talk about why it's important to look at patients' level of activity, BMI, etc., when we discuss the general health aspects. So modification procedures I think are really important. So what we'll look at first of all is we'll look at range of movement in sitting or standing versus overhead range. Is there an increase? And we'll explain why this can happen in a minute. Does it change if you actually apply something such as cutaneous pressure by the use of a compressive sleeve or a tubular bandage? What's the range of movement if you perform a bilateral movement compared to a unilateral movement? And again, I'll discuss why this might be different. And what happens if you actually get the patient to perform a functional movement involving the whole of the kinetic chain, i.e. lower limb as well as upper limb? So we know biceps EMG activity in the stiff elbow is markedly increased, and this has come from Page's study in the Journal of Hand Surgery in 2003, when you compare biceps EMG activity in a normal elbow. So that increased biceps activation is going to inhibit triceps, which is going to limit your range. Now, this is especially important if you put somebody in sitting or in the supine position with their arm down by the side. And it also is increased exponentially when you put a weight on somebody's hand as well. So when I was younger, we used to try and stretch people's elbows out with their arms hanging over the edge of the bed. And in fact, I was actually probably being counterproductive and taking 3 steps back rather than 2 steps forward. By placing a patient in the overhead position, it actually encourages triceps to actually work, decreases that increased activation in the biceps, and allows the patient to gain more range. So just by changing them from sitting to the overhead position with the shoulder at 90 degrees in the overhead position, like that, it may suddenly cause an increase in range of motion, and therefore we would get the patient to mobilize in this position. Now, we also know that the elbow has sensory deficits. It's got limited capsular mechanoreceptors and proprioceptors, and there's also a proprioceptive drift into flexion with limited higher center processing, as is seen in our friend Donald there. So that means the elbow gets a lot of its sort of sensory information about where it is in space, firstly from the cutaneous receptors, which is why sometimes an elbow sleeve can improve range. And we can see this in clinic. You ask a patient to flex and extend in the overhead position, and then you repeat it with a sleeve in place, and they can gain 10, 15 degrees range of motion. Also, that sort of limited higher center processing means the elbow sometimes takes its terms of reference about where it is in space from the other elbow. So therefore, performing bilateral flexion extension exercises in the overhead position might encourage increased range compared to unilateral motion. And if we look at adding in lower limb to overhead activation in the upright position, which would be that, then again, lower limb activation stimulates normal functional movement recruitment patterns in the motor cortex, because the brain remembers movement patterns rather than isolated muscle activities. Therefore, by adding in stepping or squatting movement 2 exercises or 2 an assessment technique, again, it might increase range. The neurological examination we're going to look at is motor and sensory function. And we know, obviously, neurological damage, especially to the ulnar nerve, can cause mediators, those neurogenic mediators of stiffness. But we're also going to look at small diameter fibres, because remember, most of the crude sensory testing we do looks at large diameter fibres when we look at light touch, etc. So the small diameter fibre loss, we would look at sharp blunt, and then changes in detections of sort of changes in thermal detection rates. So we would look at asking a patient, can they tell a difference between a coin at room temperature compared to a coin that was kept in a pocket and was kept warm. So we look for small diameter fibre changes in that. And then we'll also look at the ability to detect objects placed in the hands with their eyes closed, and also the ability to detect numbers or letters written on the hand or the forearm, which is known as graphesthesia. These are really excellent ways to get into somebody's who's suffering with a lot of pain as well as stiffness, because you can do non-noxious sensory stimulation without them having to worry about sort of moving or concentrating fully on the elbow. So it's almost kind of a distraction when we get patients to play the sock game, which is the game which is you can see on the left there, where you play against the patient and they have to find a domino or an elastic band or a toy car with their eyes closed. So muscle length tests are really important. So we mustn't forget that the elbow, the muscles that cross it are often cross 2 joints. So biceps and triceps being muscles that cross the shoulder and the elbow. And then if we think about it, the forearm flexors or the wrist flexors, wrist extensors, again, cross 2 joints. So for example, here on the left-hand side, you can see bicep length tests where you extend the shoulder, thereby reducing the length of biceps, and assess range of movement compared to range of movement at the elbow with the shoulder in a neutral position. If it's reduced in extension, that range of movement at the elbow, so if it's reduced in glenohumeral joint extension, it means you've got a biceps problem in terms of shortening rather than a true capsular contraction. And the converse is true with the triceps. So assess range of movement in glenohumeral joint neutral, and then place the patient into a glenohumeral flex position, assess range. And again, if they lose the flexion capacity of the elbow, then again, we can assume it's more of a triceps length problem rather than a true capsular contraction. Other things that we need to think about are general health, especially when we're talking about degenerative diseases. When we used to talk about degeneration, we used to talk about patients having wear and tear, and that led to the whole osteoarthritic presentation. But the more we know now, it would appear that obesity and the effects of obesity on the whole of the systemic system, including the musculoskeletal system, has a role to play in osteoarthritis. We know that visceral fat secretes pro-inflammatory cytokines, leading to metabolic syndromes. Those inflammatory cytokines cause a low-level inflammatory change, which is also, the people feel now, is responsible for cardiovascular problems, diabetes, etc., which then causes degeneration or degenerative changes within the actual elbow joint itself, as well as having the increased load to take because of the patient's increased weight. So, and that may lead to, as we said, osteoarthritis. So it's really important when we're talking to patients who have degenerative changes, not to just treat their elbow, but to treat the patient as a whole. So looking at things like lifestyle changes, general activity levels, following the World Health Organization goals of 150 minutes a week of moderate intensity activity, and making sure that the BMI stays within healthy limits. So it's not just about looking at the elbow, it's about looking at the person as a whole, and also looking at things, as we said before, such as their attitudes, fears, and beliefs. So is there an alternative way that we should be treating patients with a stiff elbow? Well, first of all, prevention is much better than a costly cure. So it's about mobilizing patients early, mobilizing them in the overhead position, using sleeves, using the kinetic chain, using bilateral activation, using both arms, etc. And making sure that we engage with patients and minimize their fears and give them realistic expectations of what to expect after trauma, etc. So in conclusion, assess the patient early, take a thorough history, and again, find out what those fear attitudes and beliefs are, because those are really important in predicting outcome post-trauma. Then you need to undertake a thorough physical examination, but also it's not just about treating one patient's joints, it's about considering the patient as a whole and considering systemic influences over their presentation and continuation of problems. So thanks very much for your attention, and I'll see you later in the question and answer session.
Elbow stiffness is challenging. Physicians must remain vigilant with efforts to prevent stiffness before it starts. Recent advancements in the biology and pathology of elbow contracture have led to improved understanding of this difficult problem, and they may lead to future breakthroughs in the prevention and treatment of elbow stiffness. The exact reason that the elbow is so prone to joint contracture is not known with certainty. What is recognized is that the elbow is one of the most congruous joints in the body, with close continuity of the muscle to the capsule, and a somewhat unique response of the joint capsule to the trauma. Joint stiffness occurs in 4 stages: bleeding, edema, granulation tissue formation, and fibrosis. The first 2 occur early, whereas granulation tissue and fibrosis occur over days to months. Experimental data demonstrate that the majority of tissue contractures occur in the first 3 weeks. This supports the concept of treatment in the early phases of healing. Contract joint capsules show substantial morphologic and compositional changes, with a thicker aspect, with a high rate of extracellular matrix turnover, an increased amount of collagen synthesis and deposition, an increased collagen cross-linking, as well as decreased proteoglycan and water content. Contract capsules have also greater absolute and proportional numbers of myofibroblasts. The myofibroblast is considered central in the development of post-traumatic stiffness. Myofibroblast number have been shown to be inversely related to the range of motion in post-traumatic elbow stiffness. A complex system of chemical and mechanical signals modulates the subsequent differentiation of mesenchymal stem cells and fibroblasts into myofibroblasts. Female sex hormones may counteract joint fibrosis and could potentially provide a target for medical intervention. Finally, there is a possibility of genetic predisposition to the development of post-traumatic stiffness. Different experimental studies from Mayo Clinic have shown promising way of medical treatment to prevent stiffness, like celecoxib or ketotifen or anti-TNF-alpha. Results of some clinical studies have shown some effect in preventing heterotopic ossification after elbow arthrolysis, but not effect to inhibit progression once it has been developed. Although the use of non-steroidal anti-inflammatory drugs such as indomethacin has proven effective in preventing ossification in the hip, but further studies are needed to determine whether they can be effective in preventing ASHO on the elbow. Recently, Kostopoulos and al. Demonstrated the efficacy of the use of post-operative indomethacin for the reduction of ASHO formation in patients undergoing biceps tendon repair. ASHO could be prevented by using low doses of radiation within 72 hours of trauma to alter the differentiation of progenitor cells in the tissue involved because of their high radiosensitivity. Studies have demonstrated that radiation was almost twice as effective as non-steroidal anti-inflammatory drugs and less risky for non-union in case of fractures. Furthermore, other studies documented a lower incidence of reintervention or recurrences of post-irradiation HO. Endomethacin in combination with radiation therapy is considered safe and effective in the prevention of HO. Botulinum toxin has also been proposed to transiently limit activity of the flexor muscles and allow active triceps contraction, which may help facilitate gains in elbow range after contracture release. Some studies have shown the interest of this injection, followed by serial cast, has increased the extension of the elbow. Continuous passive motion, or CPM, has been advocated to prevent tissue edema by the squeezing effect of tissues, driving fluid away from the joint and periarticular tissues, thus minimizing the cascade of events leading to soft tissue contractures. It is recommended that it is used as soon as possible after injury or trauma for a long period of time through the largest possible safe arc of motions. Patient may need satisfactory pain control in the form of patient-controlled analgesia or regional anesthesia. Complications of this technique include increased bleeding and delayed wound healing, with some suggestions that the use of CPM machines exacerbates ulnar nerve irritation. Recently, in a prospective randomized study, Sean O'Driscoll and colleagues have shown the interest of CPM versus only physical therapy with better range of motion at the end of the follow-up. Indomethacin was prescribed for all patients for 3 weeks. Complications were identical in the two groups. An older study from Scotland from Marie Mazeski has also shown the interest of CPM after open arthrolysis of the elbow. In this later study, no splint, no therapy, or no HO prophylaxis were prescribed. The key to the conservative treatment of this elbow is the viscoelastic nature of connective tissue, which has the ability to respond with both elastic and plastic deformity to tensile loading. Plastic elongation can be applied using manual techniques, although the use of splints has been described as being easier and more straightforward. Splitting has been suggested as a way to load tissues to increase range in the absence of heterotopic ossification. The general consensus is that the benefits of splinting are most notable in the first few months after injury, although gains may be seen in adults up to 12 months after injury. Post cessation of splinting, up to 10% of patients lose motion, whereas 10% develop a further increase in range. In the Indenoviews prospective study, there was no significant difference in improvement in motion between static, progressive, and dynamic protocols. That suggests that the choice of a static versus progressive splinting will be based on the preference of surgeon and patients. We favor the use of static progressive splitting, as it is better tolerated and shorter period of utilization may increase compliance. The exact regime for bracing is determined on an individual basis, taking into account the degree of contracture, tolerance to the splint, and rate of progression of deformity correction. Examination and manipulation under anesthesia may also be used in elbow contractures presenting at an early stage following injury. Manipulation should be attended only when there is radiologic evidence of bony union, with care taken to avoid iatrogenic fractures. It is easier to achieve elbow flexion as compared to extension with manipulation. Their benefit has been demonstrated, although not without risk. Some studies have shown an increase in elbow movement in 55% of patients, with complications such as transient ulnar-sensitive neuropathies. Other complications include periarticular fractures and the formation or increase of HO. Finally, the role of physiotherapists managing the stiff elbow is uncertain. To our knowledge, there is no comparative study evaluating the role of therapy in this context. We believe that uncontrolled therapy may exacerbate pain and inflammation and inhibit rather than facilitate mobilization. Therapy, if given, should be done in a controlled manner in close communication with the surgical team, guiding rather than forcing motion gains. Rehabilitation can prevent the deleterious consequences of immobilization and avoid excessive stress on healing tissues. 5-step of rehabilitation process that involves the correct diagnosis, control of pain and inflammation, early protect motion, neuromuscular control and integration of motion into the whole kinetic chain. The overhead position described by Wolf and Hotchkiss is the optimal mobilization position to achieve early active mobilization. This position has been demonstrated to maximize elbow stability by minimizing ulnohumeral distraction. Passive stretching can then be used to improve extension. Finally, cryotherapy may decrease pain and secondary inflammatory response. In conclusion, to prevent elbow stiffness, the first point is to avoid excessive elbow immobilization after an elbow trauma or elbow surgery. It is preferable to allow early active mobilization with protection in a safe area of range of motion, depending on the pathology. Endomethacin has proved to limit the risk of HO. In case of HO, radiation can be discussed with indomethacin. CPM can be useful after contracture release followed by a splint program. Finally, depending on the patient understanding of this pathology, a therapy program could be discussed. Thank you for your attention.
So, good evening. My name is Ingrid Hultenheim, a physiotherapist from Sweden, and together with Davide Blonna.
Hi,
we
Davide Blonna
have,
from Italy.
We are managing the Q&A session. So we have some questions. Do you want to start with one question and I take the next, Davide?
Okay, I think that the first question is for the first speaker, Dr. Singh from UK. Do you think that there can be some connection between a stiff elbow, frozen shoulder, or a Dupuytren syndrome, especially considering what you have told us about the myofibroblast?
Yes, there is, and there are studies going on it, but there is definitely similar kind of a pathology which goes on when you need healing, and that is good. But when the process goes kind of too much excessive, then it starts to cause fibrosis, and this is what we kind of see in Dupuytren's, in frozen shoulder. So yeah, there is a kind of a connection, but still we are working on it to decode it.
Okay.
It's also your experience. Sorry. It's also your experience that maybe some lady that have developed frozen shoulder in the past, they are more prone to develop a stiff elbow after a trauma or after surgery.
Yes, I mean, definitely. And also you see sometimes when a patient comes with elbow stiffness, they always have some kind of a shoulder thing also going on. And I do come across patients who have, elbow injury, and then they will present with frozen shoulder also.
Thank you.
And the next question is from Dr. King to Joaquin. Do you think you need to remove the anterior capsule routinely when doing an arthroscopic elbow debridement for osteoarthritis?
That's a great question, Graham, and I don't know that I know the answer. I think in primary osteoarthritis with mild to no stiffness, you can probably get the same outcome without capsulectomy. I think in the stiff post-traumatic elbow, which are more recalcitrant for treatment, probably it is wise to do a capsulotomy or capsulectomy. One other consideration is that since this operation can be difficult to do, as long as you're careful with the PIN and other nerves, it's also a nice way to maintain your skills. And I know that justifies doing the part of the operation, but the capsulectomy is something that requires some skills, and I think it's wise for surgeons that are doing a few cases a year to try to maintain their skills that way. Is it essential in primary OA? Probably not, but I think in post-traumatic, I would keep it. And let me turn it back to you. What do you think? Do you do capsulectomy routinely in your post-traumatic cases or not?
Well, thanks, Joaquin. I think that covers it pretty well. That really post-traumatic osteoarthritis is completely different. And you said that in your talk than primary osteoarthritis. So in my opinion, just like you said, post-traumatic osteoarthritis always needs a capsulectomy. It may or may not be done open. That depends on the surgeon. But primary osteoarthritis, it depends on what the patient's looking for. They're often just looking for impingement pain relief or having their nerve dealt with. And if they have a 20-degree flexion contracture, at least north of the border here in Canada, many people are happy with that. They get back on their farm and get into their combine. They don't care if it goes to 0 degrees. On the other hand, like you say, you know, the overhead athlete, they want 0 degrees, and they're a patient and they get a different treatment. So I think we fully agree with each other, which is great.
Thank you.
Pierre, I have a question for you. Do you think that as a surgeon, during surgery, there is something that we can do in order to prevent stiffness? For example, if you're able to reduce bleeding, or if you are able to reduce subtle form of instability, we are going to reduce our rate of postoperative stiffness?
Yes, maybe. I think the goal after surgery is to move the elbow as soon as possible. If your elbow is unstable, so you will have some problem to move the elbow. So you ask me if the elbow is unstable, if there is a problem of instability, it will induce an elbow stiffness. If you cannot move the elbow after surgery, for sure you will have an elbow stiffness. So you have to do your surgery in order to be able to move the elbow, even if you move it in a safe range of motion. As I say, there is a question about external fixator. Does the use of external fixator increase the risk of stiffness? If you use an articulate external fixator, it's a way to stabilize your elbow and to allow a quick rehabilitation of the elbow in a quite safe range of motion. So I think it can be used without risk of increasing elbow stiffness. What about bleeding? Yes, I think if you decrease the bleeding postoperatively, you may decrease the risk of stiffness also. But I don't use specific drugs like tranexamic to decrease the risk of bleeding.
Okay. May I ask, we have time for one more question. When you say that we should move the elbow as soon as possible, Val Jones, could you comment on that? What is your, when do you start? After
Immediately or immediately post-trauma if we can, but we always obviously have the conversation with the surgeons about what are the safe ranges to actually move about. So we have a safe zone that, say, if the patient's post-surgery, the surgeons will actually record in the post-op notes about what ranges they're happy for us to take them through. We'll always make sure that they're in the overhead position. The patient will always be in control, so we use active overhead mobilization. But again, we try and encourage the patients to move. So we give them sort of confidence in the ability that they can, their elbow isn't going to fall apart. As soon as they start to move it, we'll use, as we said, the compression sleeves, etc. And we say early movement is key, and you've got to move to improve.
So you never use CPMs?
We've stopped using them in our unit. We've had less elective elbow surgery anyway with COVID, but we've stopped using them because patients, they wanted to get them out of hospital as soon as possible.
And pain control is very important postoperatively to move the elbow right away.
Okay, David, do you want to close?
I totally agree with that.
Maybe can I have the time for one more question? Tjarco?
Yeah, I really enjoyed this discussion, and
A very short one.
Okay, go quick.
Okay, for Joaquin. Joaquin, do you think that we should start endomedicine right after the trauma and not just after the surgery? What do you think?
Yeah, we've been doing a lot of research, and the problem is that is this going to be truly translational and conclude that what you find in a rabbit knee applies to humans? But we do know that the cascade that creates fibrosis starts like in minutes after an injury or after surgery. So by 24 hours, all the gene changes that have to happen have already happened. So I do think that if we really wanted to prevent stiffness after an elbow injury, we should start whatever doing that is right away. And I also think that in the end, we'll be multimodal. I think the biology is too complex for us to think that one medication is going to just wipe out the stiffness. I think there'll have to be 2 or 3 acting together, may decrease in some patients the risk of stiffness. But the answer would be yes. We should start immediately after whatever we want to prevent.
Thank you very much.
Well, thank you all for your fantastic talks in this lively discussion. We're going to continue with second piece of our webinar. So we'll be switching live to Madrid. And Raul Barco from Madrid, he will show us his assessment of elbow stiffness and clinical examination. Raul.
Well, thank you so much, Tjarco, for the invitation, and I will speak about the clinical exam. Things I like to understand about the patient when they come to the clinic is basically when did the stiffness start? Was it after a minor trauma or after a surgical procedure? Then I want to know how is the range of motion going, if it's progressing very sharply or if it's just very static for weeks now. I want to know if they are painful when they use the elbow, and when I have a painful elbow and stiff elbow that has had prior procedures, I'm thinking about infection. So this is important to rule this out. And then, of course, we want to assess the neurological symptoms, and the ulnar nerve is critical. Of course, I want to understand if they've had other treatments, conservative management, orthosis, and how well they have adapted to this. Usually because they are in the clinic, they have not adapted very well. And I want to understand their expectations after treatment. And of course, there are many structures around the elbow that can produce loss of flexion and loss of extension. And also the joint can participate in limiting this elbow motion through malalignment, the presence of joint adhesions and cartilage loss. And trying to assess all these structures through a specific elbow assessment is critical. And of course, you know that having as an involvement of the joint can change our procedure. So it is important to understand this through the clinical exam. In some cases, we have patients that have undergone previous operations. It is important to document these operations, the type of fixations they've had, the type of arthroplasties they've had, if they had previous procedures over the nerves, and we have to understand the surgical scars and the approaches if we are planning on performing surgery. And sometimes patients do not know any of this information, and we don't have the letters from the doctors, and it's kind of, we have to be a little bit like detectives. So this is the clinical exam of a patient. So we go through range of motion of the patient in elbow flexion and extension. So this patient has a limit to elbow extension after a supracondylar fracture when he was young. We want to understand if the patients have impingement pain. So we assess the impingement on flexion and both in extension. And we want to understand if this is a hard endpoint or a soft endpoint, and if it's painful or not. We want to assess stiffness in pronation and supination. This patient has mild loss of pronation, and we want to load the joint to check for radiocapitellar arthritis, and also we will load the joint also to assess the ulnohumeral joint. Of course, it is critical that we assess the neurovascular structures of the forearm and the elbow. And when we assess the tinel sign, we go from distal to proximal, and this patient has a very, very positive tinel sign over the medial epicondyle, as you can see here. And it's important to document this. And now we're loading the joint with resisted arm flexion, unresisted arm extension. And this patient was stable, and we didn't carry on the exam. But then some patients will need to be assessed in elbow so this patient had a radial head arthroplasty 2 years prior, and of course we do the same exam. Of course, in these patients we want to assess the stability of the elbow in valgus and varus to assess stability, because some patients can be stiff and unstable, and this needs to be addressed. Finally, this is another patient that had a fracture of her elbow 2 years ago also. Let's see if I can put the volume down. And she had here I'm testing the stability after the fracture dislocation. She had hardware removal, and I'm pressing on the posterior medial side. This is basically because with my hand, as I'm stabilizing the humerus, I'm pressing on the ulnar nerve, which is very symptomatic, and that's why she was painful. This patient always had mild symptoms of instability, and I will use the hypersupination test and the posterior drawer test in the awake patient. I think this is more sensitive than the pivot shift test, so I will go on and assess stability also in stiff elbow. So just a note of doing that. And also some patients it's difficult to know if the endpoint is due to bony impingement or capsular involvement. So the only way to know sometimes it's the additional imaging that we can get for these patients. This is a patient that had very neurotrophic changes in the elbow with stiffness or high degree stiffness in flexion. He also had very sweaty and clammy hands. And in this patient, I performed a single stage surgery with extensive ulnar nerve release, and he did well. But sometimes some of these patients can benefit from a staged surgical procedure. The first one being the release of the nerve until it quiets down, and then if the stiffness is ongoing, then we will perform the release. So in this very dystrophic with patients with dystrophic changes, you need to assess those and be aware. Then also, as Dr. King was saying, some patients with very mild loss of motion can be very adamant in wanting a a full range of motion, perhaps if they are athletes. And so I want to learn if these patients are really very well motivated, because it's very hard to keep these small gains in motion after surgical release. And if they don't understand this, they can be disappointed at you, and it's really not your fault. So you should, it's a proper discussion to have with these patients. So hopefully I will gain some time for questions, but my take-home message is that through this clinical assessment, we try to identify the specific structures that could be affected by the disease, given the anterior capsule or posterior bony impingement or HO in the muscles or the ligaments. And that's what we try to identify through this clinical assessment. We want to assess the neurological component of the stiffness. It is important to recollect information regarding previous procedures. Some of these patients have been operated a few times. We want to go over the expected use and outcomes so that we can manage expectations with these patients. And of course, we want to identify if they will, they are willing to undergo extensive rehabilitation. Thank you so much.
Hi, my name is Roger van Riet, and I was asked to talk about surgical treatment of elbow stiffness. I have some disclosures. I'm a consultant with Acumed, and I'm also a designer of the Exo Elbow Brace by Jake Design. When there's a soft tissue contracture causing stiffness, I think conservative treatment is the main thing. When do we perform surgery? We perform surgery with failure of conservative treatment for at least 6 months. And I'd like to add that there has to be an adequate treatment and an adequate patient. And I prefer to operate if patients have more than 2 months of no improvement. What do I mean with that? If at 6 months they're still improving, I think they should continue exercise and continue physio until we have 2 months of no improvement, and then surgical treatment may become an option. Maybe a little bit different with bony reasons. X-rays and CT scans may show bony reason for stiffness, and then obviously physio bracing or other techniques may not be successful. When you see a bony reason, you have to ask yourself, can it be done surgically? Can it be done safely? And is it necessary? Is the range of motion, does the range of motion impair the patient so much they need surgery for this? And if so, they can do this open or arthroscopically. It depends on the clinical exam. Are there previous scars? Maybe if there's no scars, you might prefer arthroscopy. If there's scar tissue or hardware still in the joint or next to the joint, you might go for open surgery. Same goes for the nerve. We know that delayed onset ulnar neuritis can be a serious problem. So what does that mean? It means that if you have less than 90 degrees of range of motion, and you give the patients range of motion, especially in flexion, you might end up with a really bad nerve because you start stretching the nerve. And then you might want to do, as a preventive measure, you might want to do an ulnar nerve release or even a transposition. Obviously, it depends on the imaging. My threshold for CT scan is very low. And then it depends on the patient and it depends on the surgeon, because there is a big learning curve and stiff elbows are not the easiest ones to start with. So you need to be quite proficient with elbow arthroscopy before you start thinking of doing stiff elbows. Obviously, imaging, when you see this is not a candidate for an arthroscopic surgery. This is open surgery. With open surgery, the anterior capsulectomy is probably the more challenging one. What we do then is we go to the extensor tendon split and go anterior to the joint. This was a patient that we did open because of the calcifications on the medial side. As you can see, very little range of motion. And those calcifications on the medial side are close to the nerve. We need to open up the nerve anyway. And you might as well do this open to really remove those calcifications there on the medial side. There's the nerve. In this case, we ended up doing an anterior transposition because I thought that if we remove those calcifications, we'll end up with a really hostile bed for the nerve. It's probably better to do an anterior transposition. So we're cutting the posterior band of the MCL complex, which is one of the main reasons for stiffness in the flexion direction. Cutting the posterior capsule from the medial side. And you can even go as far as to cut the anterior capsule from the medial side. But in this patient, we decided to go lateral because of the severe stiffness. So there you go. Extensor tendon split. We go straight through the extensor tendons, go straight through the capsule, and sometimes even through the annular ligament, as you can see. And then we release the arthrofibrosis. So in this case, scar tissue is really attached to the cartilage of the capital. go inside out. So once we've found the joint, you can stay in a joint with your blade, and then you can easily remove all the capsule or release all the capsule from the humerus. I don't always do this. I don't always do a capsulectomy, but in this case, the capsule, as you can see, was nearly 1 centimeter thick. So then you need to find the plane between the capsule and the anterior soft tissues. Be careful with this because the radial nerve is close, of course, so stay on the capsule. Dr. Murray taught us to go in a V shape. What does that mean? You go wide, really laterally, and then you go more narrow in a V shape towards the medial side. Obviously, always check the range of motion. It might be a good idea to not only record the range of motion pre-op and post-op, but also make a video or make photographs to show the patient and the physio to see what they're dealing with and to see what the goal of post-op rehab would be. Arthroscopic surgery, I think most of you will have done this or will know, at least will know that it exists. This is the anterior part of the elbow. There's a groin process. We see the radial head and back. Mild synovitis in this patient, so not a big deal in this patient. This was a patient with stiffness due to arthritis, even though this was a very young patient in the early 30s. This was post-traumatic arthritis from contact sports. This is the posterior side. That's the olecranon fossa, which is supposed to be a fossa, but was really full with osteophytes. See the posteromedial tip of the olecranon. Again, osteophytes there causing impingement and causing decreased range of motion. And then finally, for our inspection, we go in a radiohumeral gutter. There's usually some synovium there or a synovial fold. No big osteophytes, but unfortunately for this patient, a cartilage lesion on the radial head. So what are the indications for arthroscopy? Arthroscopy for stiffness, I have to add. Most common, obviously, the capsule, soft tissue, cartilage, unfortunately, osteophytes and loose body, not necessarily in this order. I think loose bodies are probably the most common reason for arthroscopy. This is a patient with severe stiffness. Again, we went in with the scope and you see these fibrotic strings going from the capsule to the bone. So that's part of the stiffness as well, but it also impairs my view. So this is really annoying when you see this. You go in, there's the radial head. Now we need to create a lateral portal. And once we have the lateral portal, we go in with the punch and just cut those fibrotic strands. Once you've cut them, use a shaver to shave them away. Don't use suction because the nerve is close by, as you know, the radial nerve. And then you start releasing the capsule from the bone. So this technique is slightly different if you do a capsulectomy. If you prefer to remove capsule, then it's probably not as good as an idea to remove a capsule from the bone straight away, but then you need to go from the medial side and cut the capsule anterior to the radial nerve. I prefer to do capsulotomy in over 90% of cases. So I think it's safer and I think the results are similar or the same. So sweep away the capsule from the bone. As you can see here, it's always a little bit tough at the ridge between the coronoid fossa and the radial fossa. But just sweep away with this. You can use a sharp instrument for this as well, the same as you would open like a periosteal elevator or even a little osteotome. But it works well with the shaver. And then finally, when you end up through the capsule, so you end up superior to the capsule, proximal to the capsule, then you can just simply slide away that capsule from the bone. And you see the brachialis and the extensor muscles shining through. Osteophytes is the anterior part of the elbow, anterior impingement, so the coronoid is hitting osteophytes in the coronoid fossa. Go in from the lateral side with our burr and remove the osteophytes from the coronoid fossa itself. In this case, that may have been enough, but in most cases, we need to remove the osteophyte from the coronoid as well, and I prefer to use an osteotome for this. So again, we're looking for the medial side. Osteotome is in the lateral side. It's about 5-6 millimeters wide, and you just knock the osteophytes off. Usually fairly straightforward because the osteophytes are soft, and this is unedited. So you can see the osteophyte still attaches some soft tissue on the medial side. Just cut it, pull it away, and there you go. This is a resection. And with the burr, first of all, it takes longer, and you're always a little bit afraid of hitting the anterior trochlea with your burr and then thereby damaging the capsule. Thereby damaging the cartilage. This is the back of the elbow, looks almost exactly the same as the front, so we won't talk too much about this. We feel pretty safe at the back, except for the posteromedial corner where you're looking at now. See those little osteophytes that are fractured? They're still inside you, and these cause pain, and not only mechanical problems with extension, but also because of the pain. Here's a patient again with similar problems, fractured osteophyte on the lateral side in this case. And there you see my osteotome. You knock it off, and in your mind, you just create a new, you create the old olecranon, because you don't want to take off too much, especially on the medial side, because you don't want to induce medial instability. It's not as bad as stiff patients. I don't think the 2 millimeter rule really counts for stiff patients and for arthritic patients, but especially in throwers or athletes, you need to be a little bit careful not to remove too much from the posteromedial side. So remove all that bone. Same way as you do at the front. So get a grasper, remove it, and then with the burr, you just clean up all your edges and make sure that it's nice and round. And at the end, you might want to change portals and check for further impingement. And finally, loose bodies. This is a professional tennis player. He was happy for me to share his images. He called me from the US Open, and he had a blockage of his elbow, which was caused by loose bodies that were actually diagnosed more than a year before, but because he was still able to play, he didn't want to have surgery. And unfortunately, despite his young age, he already developed huge osteophytes at the front of his elbow. This in the back, again, osteophytes there, some soft tissue, some cartilage damage. There you go. So quite a lot of damage from his elbow blocking because of those small loose bodies. He started physio immediately. Jill Thomas will talk about this, so we won't go into detail here. I really enjoy these images of him. He's really fast, as you can see. I really enjoy these images of him doing functional training. So the physio is not necessarily touching him too much. Obviously, this is a young guy, and his stiffness caused by pain, caused by his blockages. And less than 2 weeks after surgery, he regained his full range of motion. And less than 3 weeks after surgery, he was on the pitch again. On the court, sorry. So contraindications, is the ulnar nerve a contraindication? I don't think so. It's a relative contraindication. The nerve might be dislocated, like in this case, but what we do then is we just relocate it behind the cutter, in the cutter, with my finger when I put my trocar in, and that's fine. I talked about on delayed onset neuritis already, where we need to be careful with really stiff patients, or when you think afterwards there's going to be a conflict in the gutter, and you might want to do a mini open. If there has been an anterior transposition of the nerve before, I tend to not rely on ultrasound like other people, because I think the external markers might shift when you start inflating the joint. But what we do is we do a mini open, so we really see where the nerve is, and we actually do a mini open release of the nerve, just to identify it. This is the most important contraindication, surgeon skill. So if you're thinking about doing upper arthroscopy, look at your skill, don't go over your skill set. Tell the patients that you might want to open up during surgery because it might become too difficult for you, and definitely do this. What are the results? Average arc of increase from 85 to 115, most increase in the first 3 months. Not a lot of difference between 3 months post-op and a year post-op. Vast majority will improve. 60% gains more than 20 degrees, and 30%, so 90% gain between 10 and over 20 degrees. 12%, so 7% had no change, 1% even lost some motion in this post-presentation from John O'Driscoll. There's no real difference between open and arthroscopy, according to Denise Eigendal. She looked up her patients, consecutive patients open, consecutive patients arthroscopic, and we can expect about a 30-degree range of motion gain in both groups. So this is what I tell my patients as well. And that's why it's so important to really, really go ahead with exercises pre-op. And as long as you're still winning, the better you are before surgery, the better you will be after surgery. Obviously, sometimes arthroscopy is not the best option. I overestimated myself in this patient, but he was 51-year-old, and the other option would be total elbow replacement. So we did an arthroscopy. He was okay for like 6 months or a year, and then we ended up doing prosthesis anyway. I know Graham King is talking about stiffness following elbow prosthesis. This is a case of stiffness before an elbow prosthesis. As you can see, severe degeneration of the joint. The joint is nearly gone in a rheumatoid patient. This is the post-op X-ray, and this is her 1 year post-op. So although I don't think total elbow replacement is a treatment for elbow stiffness as such, it can help for elbow stiffness. So conclusion, treatment of the stiff elbow depends on etiology, depends on the joint, depends on the patient, depends on the surgeon. And good results can be obtained with conservative treatment, open surgical treatment, arthroscopic treatment. And like I said, good results, but not always perfect. I tell the patients, you will not get a new elbow, but hopefully a much improved one. Thank you.
Good evening. It's a pleasure to participate in this webinar on the management of elbow stiffness. My topic tonight is to focus on stiffness after elbow replacement. I do have relevant disclosures related to this topic as I receive royalties, and I'm a consultant for Stryker. I think the most common reason to end up with a stiff total elbow is that the elbow was stiff to start with. Here's an extreme example. This 32-year-old patient with juvenile rheumatoid arthritis presented to me with bilateral fused elbows. She could not feed herself, and she required constant assistance for activities of daily living. She was treated with an unlinked total elbow replacement with a triceps on approach. Here she is 4 years later. Now, her elbow is still stiff, but she was actually delighted with her outcome, as she was now independent as a result of having bilateral elbow replacements for the management of her two fused elbows. Again, for her, this was transformative, but again, you can see the elbow is still stiff with barely 90 degrees of flexion achieved, which I suppose is not surprising as she was fused preoperatively. Here's another example. This is a 78-year-old lady who has both rheumatoid arthritis and osteoarthritis. You can see the extensive osteophytes, and she only had a 30-degree arc of motion. Now, of course, putting a total elbow in this patient is challenging, as it does require you to do a contracture release, excise all that extra bone, and then finally put in a linked arthroplasty. That was done here, and here she is 3 months later. Again, you can see her contralateral left elbow is actually quite stiff as well, but she was very delighted with the outcome of her right total elbow arthroplasty. But again, you can see she does not have full extension nor full flexion, but for her, compared to where she started, she was very delighted and happy with the result of her arthroplasty. Again, if you start stiff, you're going to end up somewhat stiff. I think the other thing that we can see in elbow arthroplasty that results in stiffness is any issues related to the wound. Here are some examples I have had over the years of problems with total elbow arthroplasty incisions. Granted, most of these patients were on steroids or TNF inhibitors, but suffice it to say, these are devastating when they occur after an elbow replacement. Sometimes simply waiting on the wound allows it to heal, but other times it has to be addressed, in this case with a reverse radial forearm flap for complete full thickness necrosis. This, of course, results in significant stiffness as rehab has to be delayed until wound healing is secured. So trying to avoid these kinds of flap problems is key when performing an elbow arthroplasty. Some strategies are to minimize elevation of the flaps, use techniques such as wound vacs to avoid seroma hematoma, immobilize the elbow post-operatively until wound healing is secure. Those are all things that I found helpful to avoid flap necrosis.
I think the other thing is that actually surgical approach matters. If you cut the triceps off, as you can see here on the left with this triceps peeling approach, and compare that with some type of triceps on approach, the right side shows the lateral paralecrinon approach we reported about 10 years ago, the results are different. In this paper by Dax, they compared the range of motion of triceps off to triceps on. And as you can see, throughout the time period, the triceps on patients have much greater range of motion than those where the triceps is detached. And this has been our experience as well. So if you want to optimize range of motion after an elbow replacement, try not to detach the triceps, or at least not completely. I think the other technical thing is that if the components are placed too proud or incorrectly, this can affect range of motion. This patient with rheumatoid arthritis was treated with an elbow arthroplasty. And here she is 10 years later. Now, her elbow arthroplasty is functioning well. It's an unlinked arthroplasty with a radial head replacement. But you can see the humeral component is placed at the green line, far too proud of the anterior inferior aspect of the medial epicondyle, which is the blue line. So by shifting the humeral component distally, this is going to limit your ability to extend the elbow. Trying to get the humeral component as well as the ulnar component in the optimal position will result in less stiffness after elbow replacement. And that's a technical factor that you can control during elbow surgery. Obviously, if we had some type of device to try to control this better, for example, using image guidance or patient-specific guides, surgeons could place the components more accurately and avoid stiffness in the postoperative period. I think the other issue relates to impingement with implant placement. You can see here this patient has a pre-existing ulnar deformity after a pre-existing distal humeral as well as radial head and proximal ulnar fracture. While the elbow replacement was put in satisfactorily, you can see here the patient had limitation of flexion, and this was due to impingement of the coronoid on the anterior flange. This has been very common in elbow replacements that have an anterior flange. Almost all elbow replacements do. So when you're doing an elbow replacement that has an anterior flange, check intraoperatively and make sure there's no impingement of the coronoid on the anterior flange in flexion. I routinely do this, and in fact, I routinely excise the tip of the coronoid in almost all patients undergoing an elbow replacement because I find flange impingement is extremely common. And in this paper by Emily Chung, not only did she show issues with reduction in flexion, but more importantly, pistoning of the implant and early loosening of the ulnar component. So avoiding flexion impingement can be a technical factor that is, again, under the surgeon's control. Well, heterotopic bone is something that is not under the surgeon's control. This patient, who is 53 years old, has rheumatoid arthritis and had a prior radial head excision. You can see here the advanced destruction of her articulation. She was treated with a total elbow replacement, but as you can see, she only has 25 degrees of elbow range of motion. She got massive heterotopic ossification following her elbow arthroplasty, which I would have to say is rare, following a total elbow replacement in a rheumatoid patient. This, of course, would have to be treated by excision of the heterotopic bone in a secondary surgical procedure. This can also happen with distal humeral fractures. In fact, it's not infrequent after a total elbow arthroplasty for a distal humeral fracture. You can see here in this elderly lady, 92 years old, that after an elbow replacement, she had good but not perfect range of motion, a block deflection due to the formation of anterior heterotopic bone abutting the coronoid in elbow flexion. Again, I think for her, she was very happy with the range of motion and she returned home. Here she is just 6 weeks later, coming in from home, obviously functioning quite well. So in conclusion, when we talk about total elbow arthroplasty stiffness, think about preoperative elbow stiffness as a primary cause of this condition. Again, intraoperatively addressing the capsule, any extra bone that's blocking motion, and an early careful rehabilitation program may mitigate this. But in spite of this, an elbow that starts stiff is more likely to end up stiff after an elbow replacement. No different than when you're doing an elbow contracture release. Wound problems are to be avoided. They definitely delay onset of rehabilitation. And as a result, elbows tend to be stiffer if they end up requiring soft tissue reconstruction to manage wound deficiency. Triceps off surgical technique, that tends to, of course, result in more stiffness and leaving the triceps attached. Perhaps some of the new triceps detaching approaches may have an improved outcome. Time will tell as data is needed on some of these newer approaches to detaching the triceps. I think there's technical factors such as inadequate soft tissue release, incorrect placement of the components, and failure to remove impinging bone on both the coronoid and olecranon during the elbow replacement. You need to check the range of motion intraoperatively to ensure a good range of motion is achieved. When in doubt, fluoroscopy can be used to assist. I think heterotopic bone can occur with elbow replacements, most commonly seen in fractures, and to date, we really don't have a definite treatment to prevent this that we would certainly use in elbow replacement surgery. For example, radiation is never going to be used for treatment of elderly patients undergoing total elbow replacement for distal humerus due to the potential wound issues. So it's something that further research is required. Well, thank you very much. This was really just an overview of some of the causes of stiffness after total elbow replacement. It's not particularly common, but there are some things to consider and some things you can do to avoid it. Many thanks again for inviting me to this webinar, and I look forward to questions and discussion. Thanks again.
That it isn't moving. It's surrounded by very mobile joints. The shoulder, wrist and hand are very mobile and can compensate very well. The elbow will put the hand in a sphere and the elbow will get the hand to where it needs to be. The upper limb will get the hand to where it needs to be. So to do that, it usually compensates at the shoulder in that if you reach forwards, you'll see that shoulder come forwards as the patient there. Or if the elbow doesn't flex, the wrist will flex to try and compensate for that. So often as these patterns set in, the patients continue to use them unknowingly to them because their hand is still getting to where it needs to be. It is all about teamwork. The surgeon alone isn't going to fix it and the physio alone isn't going to fix it. So the first questions are, is it stable? If it's not stable, it needs to be stable, and that's where we need to talk to in a multidisciplinary way to our colleagues. So how do we improve the range of movement once it is stiff? Well, we need to look for the door in, and that takes a little bit of playing around as in terms of assessment, as Val would have talked about earlier, but really trying to work out what's going to work for that patient. So generally, I start with some overhead mobilisation. And as we know in this place, in this position, we can reduce the effect of biceps and brachialis, and often the patients have more range of movement. So if we take this chap, for example, who has 45 degrees of extension from 0 in standing, as soon as we put him in the overhead position, it increases to 35. So we can certainly use this to try and gain extension. But can we go beyond? That, because it gives us range of movement and stability, it gives us opportunity for fracture repair if we're still within that phase, but it's not functional. It is a little bit boring lying on your back doing more exercise. You need to lie down, so it's not very accessible for somebody who's at work, for example, and it's not comprehensive rehab. You're not going to get them back to what they want to do. We know that it is safe from Graham King's work, that even the unstable elbows can do that. And it's a way for tapping into that stiffness whilst they may wait for surgery, for example, or whilst a ligament is repairing or healing. What we want is the gold standard of rehabilitation. So we want it to be functional. We want to regain really good strength, and it needs to be patient focused and individualised. So what else do we need? Well, we need to remember that the elbow is the proprioceptive deficient relative. We have limited capsular mechanoreceptors or articular proprioception. They proprioceptively drift into flexion. We have limited higher level processing, and we rely on the muscle spindles from two joint muscles. So we're asking ourselves, do the patients actually realise when their elbows aren't moving? Do they realise that they're getting stiff? Probably not. So if they don't know when it is moving, if we're giving them an exercise to try and move it, unless we increase that proprioception, they're probably not going to realise when they're doing it whether or not the elbow is moving, or are they just exercising their shoulder, wrist and hand very well. So we can do this by increasing and enhancing afferent inputs. We can utilise cutaneous receptors. A lovely study looked at the effect of tuber grip versus intra-articular lidocaine, and tuber grip on joint position sense. Tuber grip had a far greater positive effect than the lidocaine did negative. So just by putting that tuber grip on can give us some input. So this patient, for example, had a 62 to 85 degree arc, and she's a post-trauma stiff elbow. I literally put the phone down, stop recording, applied the tuber grip, and we increased the arc to 44 to 113 degrees. So that's a huge increase just from literally placing some tuber grip on, which is simply hugging that elbow. We can consider muscle spindles and the position of those, and we can use vision and imagery, working within the visual field, making sure that the patients can see what their arms are doing. We can also make sure the movements are active and that they're bilateral activity, so that we get a crossover effect in the motor cortex, and of course utilising our kinetic chain and more functional movements that their body's used to. So applying it to rehab, every exercise that we choose, except for that overhead exercise, we need to be adding some tuber grip, using visual feedback, making sure it's a bilateral exercise, making sure it's active, had the hands leading the way as they would do functionally, make sure it's goal driven and include that kinetic chain, but obviously not forgetting any ongoing stability or fracture or soft tissue healing. So how do we put the icing on the cake on that exercise? A simple wall slide to try and increase the elbow range of movement may turn into this. So here we've added some tuber grip, we've added TheraBand, we've added a towel to increase the slide, we're doing a bilateral, and we've got the eyes on the game. Ticking all of those boxes. But for some patients this won't work, and we need to be mindful of that. But we go back to basics and find out what's going on. So we need to remember that that elbow was normal at one point, and we can go back to doing things that that patient did every day. So tap into the sports that they've done, tap into their usual work. If they've got a repetitive job, use that movement to get that elbow working again. And the elbow movement is dependent on that motor endpoint, and that's going to drive that change in that muscle stiffness. So keep it functional and think about it, and also think of those developmental stages of the elbow. So what have they done since they were very young? So we forget about the elbow. We think use visual cues such as a balloon. Place a balloon in the hand and say move the balloon rather than bend the elbow, which is not something we think of day after day. Use things such as ball throwing and catching, crawling, for example, for those patients that crawled, and those normal work activities. And hopefully we gain some improvement there. But again, for some individuals, you won't get in through that window either. So they're the ones that you probably need to talk to a little more. Why do you think your elbow is not moving? What do you think that you've not been able that you've not, why do you think you've not been able to return to work? What do you think's stopping you from improving? And they'll often tell you the answers. And once you start talking to them, that they really start to share with you. So my delightful patients of recent years, elbow trauma patients, have said such comments as these to me. It was only a little slip, and now I can't even wipe my bum. I slipped off the lorry. I was unloading on my own. They're bothering me about when I can go back to work. I missed my footing. I can't work. I can't pick up my grandkids. 2 weeks ago, I was normal. Now I've got an arm that isn't mine. Fracture clinic said I need an op. I came in, didn't eat, saw someone else. They said I didn't need one. Who's right? And what we're forgetting is that it's called elbow trauma for a reason. And it is quite a traumatic event for many patients, and we need to respect that, and we need to maybe address the other factors around the elbow to try and help get that elbow moving. So can we predict those who will have poor outcomes, we might not improve until we sort out the other things? Well, we know that stress and depression is associated with ongoing disability, and anxiety in upper limb fractures is common, also associated with disability, along with the ongoing litigation and psychological distress. Now, we can't change all of those, I mean, not in any mind, but I think we need to be mindful of the greater picture that surrounds that elbow and where the elbow fits into all of that. And you will find for some people that addressing those things, waiting until they've settled problems at work, waiting until the big family event that's been stressing them out, such as a wedding, as one patient did have. She came in after the wedding and the elbow moved, and it literally had not moved. It was solid before that. Using those things and talking to the patients about that will help. So to get this elbow range of movement, we need to make sure we've got the icing and the final decorations on the cake. To get the achieving the goals and back to work and play, the range of movement, strength, the proprioception control, but mentally in a good place regarding the elbow. I'm not saying I have all the answers for that, certainly, but there are lots of different clinicians out there that do. Often it's a case of just talking to a patient or acknowledging that to them. Though there are some that have a lot greater problems that's way outside my scope of practice and expertise that would need to go and talk to somebody else. So making sure we strengthen them, get them back to where they need to be at the end of the stiffness.
So I think everyone's back in the room. I'm sorry, Jill, there seem to be a few technical issues with your presentation. I know it started halfway through your presentation. Is there anything that we missed in the first 3 slides that didn't show up?
Oh, the best slides, Val. They were the best ones that everybody missed.
You can show them now, Jill.
It's fine. My key message at the beginning was important, actually. Was that it is all about prevention, and everything that I was talking about can be applied to prevent stiffness just as much as it can be applied to manage stiffness. So if we can prevent it in the first place, we're obviously in a lot better position.
Okay. And then we have one other question, as we've had a couple actually that are physio related. So how much time after an open release of a stiff elbow with HO do you consider necessary to continue with physical therapy for?
Is that for me, Val?
Yeah, that's for you.
Yeah. So we commence physiotherapy from day 1, if not education from day 0 or preoperatively, and we would continue until they gain their achieve their goals, their functional goals, return to sport, return to work.
And then one other one from Graham King. Jill, we have struggled to provide in-person therapy during the pandemic. What is your experience with virtual therapy, and do you see that as having a role in the future?
Well, thanks, Graham. Well, it's been a steep learning curve. I think most physiotherapists who've been providing online provision would agree with me. I think there is a place for it, and certainly for those of us who have patients who travel a long way, then it's great to make it much easier for them to see us on a more regular basis. I still like to be able to see the patients face to face, put my hands on their elbows, and to really make sure they've got the technique, in particular with the proprioceptive issues in the elbow. It's so easy for them to compensate with the movement of other joints, and that's really hard to get the correct camera angle on to achieve that. So I do think you're better in the first instance to see them face to face, to make sure the technique's good, to make sure the movement's coming from the elbow, but then maybe place some online meetups in between the other face-to-face appointments.
Okay.
So a question to Dr. King. Does the etiology leading to the arthroplasty increases the risk for stiffness in the post-op?
Well, thanks for the question. I think it does. I mean, in our experience, rheumatoid patients that are stiff to start with, they improve a lot more than a post-traumatic elbow, where there's been hardware in, you know, a number of surgeries already, and then you're coming into kind of as a salvage procedure. So when you've got those kinds of, you know, disaster elbows and you're coming in to kind of clean it up and put in a total elbow, I think those patients tend to form more fibrosis, and they secondarily have more likelihood of getting heterotopic ossification for whatever reason. I think it's often, you know, we think that some element of heterotopic ossification may be neurogenic. Often those people already have nerve injuries from their prior surgeries. And so hopefully it's not me, but, you know, even remobilizing those ulnar nerves after 3 or 4 operations sometimes makes it work less. So I think they get some neurogenic contractures as well. So I do think it matters. So the post-trauma elbow, in summary, tends to be worse than taking on a primary rheumatoid patient, or quite frankly, a primary fracture. So total elbow for fracture, if they don't tend to get stiff in our experience, they tend to move pretty well unless they get heterotopic ossification. So that we haven't solved.
Thank you, Dr. King. And a question to Roger Van Riet. What are your current limits for arthroscopic release in elbow stiffness?
It depends on the patient and the etiology, like I said. So if there's hardware retained, if there are lots of scars, then I often end up doing an open release instead of an arthroscopic. The stiffness itself is not a limitation. So we can have very, very stiff elbows that we still do an arthroscopic release on, depending on the nerve, of course, like I said. So I would recommend either releasing the nerve or even doing a formal transposition if it's very, very stiff, and then continuing with the arthroscopy. So the stiffness itself is no problem. It's mainly, you know, the reason for the stiffness. I know Sean O'Driscoll has been doing heterotopic ossification removal arthroscopically. That's something I don't do. I weigh up the risk to the potential gain of the technique, and I think if arthroscopy is of added value, then I do it. And the added value is mainly in the view. You get an excellent view, you get an enlarged view. You can see all the compartments of the elbow, which even if you're a really good open surgeon, there's still no way you can look around the elbow as well as you can do with arthroscopy. So loose bodies, for example, very simple to remove arthroscopically, and they can be very challenging when you do this open.
Thank you.
I've got another question for Jill. Jill, we've got a question about an 11-year-old who's 6 months post-trauma with reduced elbow flexion. Family doesn't want surgery. They've tried splinting. And have you got any treatment ideas focusing on flexion for function post-injuries, pain-free with no neurological involvement?
I think first thing to say is an 11-year-old post-stiffness is quite unusual. So we probably have to be very clear that it is true stiffness and nothing sinister otherwise, no congenital problems, no instability problems, etc. So they need a full multidisciplinary team assessment from surgical and therapy team. If we decide it is just a stiffness problem, then lots of ball throwing activities. You can do ball overhead activities to increase flexion. Ball rolling, weight bearing activities also into a press up position.
Okay, thank you.
So we had from the first talks a question to open to all the speakers regarding the use of external fixators operatively in the setting of traumatic elbow instability, if they think it contributes to elbow stiffness, and when should the external fixator be removed?
Maybe I can start the discussion. Depends whether it's a hinged elbow external fixator or a rigid one. Rigid ones, I think, have a very limited role in elbow surgery. I personally haven't used an external fixator for maybe 10 years, but it does still play a role in many good surgeons. So the external fixator is used when you do a surgery for an unstable elbow, and even with the best of your abilities, you still can't get it completely stable, and you want to protect your reconstruction or repair. And the external fixator itself has to be placed perfectly. We did a study while I was at Mayo 20 years ago that it's very difficult to get the axis completely right. If it's not perfect, you might end up changing the axis of the elbow a little bit, and you might end up inducing stiffness. So I think if you do use an external fixator for the elbow because of instability, then you probably have to remove between 4 to 6 weeks, and don't leave it on longer, because the added value of the external fixator, protection of the soft tissues while they heal, it's probably not that much anymore after 6 weeks. That's what I think.
Thank you. Dr. King?
Just a note, we've actually published a paper with Scott Steinman using static fixators for elbow trauma, and showed most patients actually recovered good range of motion after removing the fixator. And we also have some work that we're about to publish on the use of bridge plating, that is a plate placed across the elbow as a temporary fusion after very severe elbow instability. Again, we're finding similar results. Once you take the plate off, we just do a limited posterior capsular release manipulation, and those patients generally have not needed a secondary elbow contracture release. So I do think it should be in the armamentarium of elbow surgeons. When you have a very unstable elbow, you've done everything you can, and it's still unstable. It's pretty hard at that point for the average person, and I consider myself an average surgeon, to then start putting on an articulated external fixator after working on the elbow for 3, 4, 5 hours. So putting on a static fixator or bridge plate, I think for all of us, is a good way out. Make the elbow stable, and we can always come back and do contracture releases, as Roger so nicely showed us how to do that if they end up stiff. But surprisingly, most people get functional motion without doing a secondary surgery.
So if I remember correctly, Graham, you leave them on for about 4 weeks?
Actually, it really depends.
Longer.
It depends a bit, Roger. I mean, if you've got a secondary surgery you're coming back on, doing ligament reconstructions, I believe left them on for 3 months. But we generally like them off by 8 weeks for sure. Often at 6 weeks, but not. I think Bernie used to take them off around 4 weeks, Dr. Mori. But I think for me, it usually 6 or 8 weeks.
Yeah, that's the dynamic external fixator, I assume. Yeah. But the static ones, how long did you leave them on?
Yeah.
Or your bridge plate?
6 to 8 weeks. Yeah.
Okay.
Yeah.
And what do you think the difference is between using a plaster, which is a disaster for the elbow, and immobilizing in the next fix for 6 weeks without having, too much stiffness? Why do you think that is?
Well, of course, the population I'm using, they already have typically heavy arms, and that's why they're redislocating. So putting on a plaster just makes the whole situation worse. We were kind of shocked that we expected to do a contracture release in all those patients. We told them, we're going to put this on, we're going to put a bridge plate on, and we're going to operate on you again. Well, of course, with a bridge plate, you do operate again because you make an incision to take the plate off, but we never do an anterior capsulectomy at time of bridge plate removal for elbow instability. Just do a little posterior capsulectomy. And most of those patients have been able to recover range of motion. I'm not quite sure why, Roger. I don't know. Maybe that's sometimes when we move things too much, maybe we cause more scar. We always thought that you should move the elbow day one after an elbow injury. I can tell you that's why I was trained in Toronto, but we all know that it's probably not a good idea to move someone day 1 or 2 post-op. You might want to wait a few days for things to settle down a little bit. So it's a bit of a mystery.
Interesting.
Jagwant, have you got something to say? Your hand's up.
Just wanted to ask that, have you had any experience, Dr. King, with the new InFix, the internal external fixator?
It's not approved in, they're not available in Canada. So that it's not been brought north of the border because they can't, it's not financially feasible, but hopefully someday we'll see it. Have you used it?
Yes, we've used it a few times. So I think it's a good option. And then you can take it out at about 2 to 3 months.
I think it makes good sense. The only thing I worry about is the population I'm dealing with are often older osteoporotic females, and our experience with a pin through the axis of motion, and Roger would remember this as well, is when we used to put the pin in the fixator right through the axis of motion of the elbow, it got loose pretty quickly. So I think it would be good technique for the young trauma patient, but I think most of my patients I'm needing an X-fix are actually not the young trauma patient. They're actually old, heavy, obese people where the elbow won't stay in. And I'm not sure it's going to work there, but I'm hoping to try it.
Yeah, I think the problem also is that the pin goes in the same place where you do your LCL repair. So normally I put my anchor there, but then it's a pin now, and you don't want to put an anchor near to the pin. So that's an issue.
Well, thanks all the speakers, because I find it very fascinating how we're talking about stiff elbows and having then all these technical details about external fixators. So with all this elbow knowledge available here this evening, I think this was a very fruitful webinar on managing elbow stiffness. I would like to thank you all. The upcoming meeting in Dublin, we'll be having another SECEC user combined meeting, and we can maybe discuss face-to-face again, and hopefully we'll meet each other in Dublin in September. Big round of applause for everyone again, and maybe we can have some discussion later in the chat or somewhere else. I would like to wish you all a good evening, and thank you very much for joining us this webinar. Bye.